Great, thank you so much for having me. I am going to give you a brief update of the Bureau and all things Ryan White. Next slide. So I have no, oh, I'm doing the slide, sorry. My slides are not going, hold on. There, I have no financial disclosures. So the agenda today, I'll update you on things around the Bureau and then within the program itself, including a data update, talk a little bit about our ending the HIV epidemic activities and have some time for Q&A. So our vision is optimal HIV care and treatment for all to end the epidemic in the US. And specifically, in addition to providing resources and grants, we also provide leadership to advance HIV care and treatment, to improve outcomes and to reduce disparities. And we can document, we've been doing that. So thank you for your incredible, important work. So first high level idea is that the Office of National AIDS Policy, which is the HIV office in the White House, has been reconstituted. Harold Phillips is the director of that office. He used to work in our Bureau. He's worked in Ryan White for a long time, so we're very excited about that. And they are going to take the previous strategy that was done at the very end of the last administration and just provide some updates to make sure it reflects all of the priorities of the current administration. As well, there is the first ever National Strategic Plan for Sexually Transmitted Infections that was written, and we are now working on the implementation plan for that. And we've had a National Strategic Plan for Viral Hepatitis in the past. That has also been updated, and we are working on implementation. So a lot going on at the national level that will impact at the regional level and local level as well. Excitingly, we are having our National Ryan White Conference on HIV care and treatment, August 23rd through 26th in Washington, D.C. We are not necessarily going to have the clinical conference at the same time. So it was great that we got that polling done today to give us a good sense. And the plan right now is that we are going to have this conference be a hybrid, have people in person if that's possible, as well as have people be able to connect virtually. So for our COVID update, I really wanted to focus on provider burnout. I know this has been a huge issue. Burnout, which I'm sure some of you have experienced in the last year, is really sort of the meeting point of feeling ineffective, cynical, and exhausted. We had a problem with burnout before COVID, between 35 and 54% burnout rates among healthcare providers, and that has just really skyrocketed, including feeling depressed as well as being clinically depressed. So we know COVID and just the incredibly complicated epidemic we've been in, not just from a public health perspective, from a clinical perspective, and also from a political perspective. It's really been very tough and it's rolled downhill. Within the Health Resources and Services Administration, we are really thinking about what we can do at the organizational level. So it's one thing to tell people to go and take care of themselves and do self-care, and of course that is important. But strategically, how can we help organizations really cultivate a workplace where they foster wellness in the workplace among people who are in the healthcare professions? So there are a number of things that we know we can do in order to really foster a workplace that's going to help people reduce the chances of burnout, or if people are burnt out, to make sure that they can get the care they need so that they can recover. Specifically in the American Rescue Plan, which was some funding, there was $103 million that came to HRSA, and HRSA has advertised 3 grant opportunities. One was to promote resilience and mental health among the health professional workforce, really talking about that culture of wellness. How can we have grants to organizations to really promote a culture of wellness? We also want to make sure that we have this integrated into training so that people that are being trained are understanding about the importance of resilience and gaining some of those skills that they need to carry forward. And finally, we are going to fund 1 TA provider to help these organizations that are getting this grant do a better job and maximize their abilities to really work on resilience. Turning now to data updates within the Ryan White program. Those of you who have been here before have seen this slide, that we serve over 500,000 people every year in our program. The only thing that really changes is every year more people are aging with HIV, which is a huge success and will be interesting as we reflect on the beginning of the epidemic at the end of the night where that was not happening. Almost half our people in the RWHAP program are over 50. 3/4 are racial and ethnic minority, and a majority of them live below the poverty line. What has changed, as I said, is that people are aging with HIV. If you look on the left is our 2010 data. You can see that a majority of people were 54 or younger. And now we are really seeing those people aging with HIV, which means we need to think about how we can provide care differently in order to meet their needs as they're aging. Both in the RWHAP program, obviously the medical care and the comorbidities that occur, but also some of the issues as people are aging with HIV, including social isolation, issues of stigma and discrimination as LGBTQ people are entering into some of these aging resources that exist in the community. In terms of our data too, we like to show this slide, which is really showing us how we are able to document decreasing disparities in the RWHAP program. So it's a little bit complicated. I'm going to walk through this slide. This is viral suppression by different specific key populations. So in the first set of bars, the dark blue is viral suppression in 2010. That was 69.5%. In 2019, it's 88.1%. So we've improved viral suppression nationally, which is the work that you all are doing among people that come into the RWHAP program at least once for medical care, is improved 18.6 points in the last decade, which is really remarkable. When you look across that dotted dark blue line on the bottom, you can see that we had some disparities. Specifically, if you go over several bars to the youth, you can see that youth in 2010 had a viral suppression rate of 46.6%. So huge disparity compared to the national average. And now when you look at the lighter blue bars, that's viral suppression rate in 2019, you can see that youth in 2019 still had disparities compared to the dotted line, which is the national average. So their viral suppression rate, which was only 79.4%. So a disparity gap existed. We significantly closed the disparity gap there because whereas the national average was 18.6% improvement, among youth, we had a 32.8% improvement. And you can see similar closings of the disparity gap across multiple groups, including Black, African Americans, transgender client, and those unstably housed. The unstably housed did not have a big improvement in their disparity gap. And really what we have learned is that in order to get unstably housed people, help them get virally suppressed, we need to get them housed. The other thing we've done in the data realm is we have developed a data dashboard called the Ryan White Compass Dashboard. It also allows for benchmarking. And it's really an opportunity for users to interact with and visualize Ryan White data. We can look at the program reach in terms of demographics, the impact in terms of viral suppression and retention, and outcomes. And the goal is really to help people at the community level better use data as they do planning. So in terms of impact, this is just a screenshot of what the viral suppression dashboard looks like. So you can see it nationally, and then you can see within your own local site, as well as among specific key populations. We also allow people to benchmark, so to compare their jurisdiction against other jurisdictions on a number of different parameters. So if you're interested, I would have you spend some time looking at this if you do use data when you're trying to decide how to invest your resources in the RWHAP program. This can be found at targethiv.org/RWHAP HIV/AIDS program compass. I mean, you'll have these slides so you can click onto these links later. In terms of specifics of the RWHAP program, there are a couple of things I want to highlight. One is when we were able to travel in 2019 and talk to people about what we needed to do differently in order to end the epidemic. We heard repeatedly that stigma was a huge issue and we needed to do more to end stigma. So we were able to fund a cooperative agreement called Escalate, which is ending stigma through collaboration and lifting all to empowerment, which is specifically to look at reducing stigma at the systems level, at the individual clinic level, and at the level of individual people with lived experience. We also heard that we needed to do a better job of community engagement and having people really able to more fully participate in some of the Ryan-White planning, which takes quite a bit of knowledge of public health and epidemiology. A lot of words are thrown around, and it can be very tough to be at those tables and really feel you can fully participate. So we had funded something called the Block Project in the past, and we extended it through the Elevate Project, which is really to develop leadership to help increase engagement of people with HIV in activities related to the Ryan-White program, specifically also to get people ready to be patient navigators and to now support organizations to hire people a living wage to do this work. The other thing we've been working on for a long time is really implementation science. As I say, we are the I in implementation science. And we know that in this country, we can end the HIV epidemic. We have the tools we need, and people have done a lot of really innovative things to reach the people that we haven't successfully reached. But those are often things that are not published in peer-reviewed journals. Or even if they're published in peer-reviewed journals, they're still sort of out of reach. So we have developed what we call the Ryan-White HIV/AIDS Program Best Practices Compilation, which is a website where you can search for things like how to engage young Black men in care, and you can pull up and sort different types of interventions that people that have done that are evidence-informed interventions. There are data to show that they work, and really this provides tools like what is needed, how much did it cost, who was involved to do these various initiatives. So we're really excited to get this going. It's just launched. There are some interventions there, and there'll be more coming in the next year or two. So here you can see what it looks like when you actually go to the page. You can search for the level of evidence, the populations, and where on the continuum of care people were focusing their efforts. Once again, at targethiv.org. Turning now to ending the HIV epidemic in the US, this is an initiative that's envisioned to be a 10-year initiative to bring HIV case and new HIV diagnosis to less than 3,000 per year, which is the WHO definition of ending the epidemic. These are new monies that are initially going to 50 cities/counties and 7 states. The cities that were focused on were those cities and counties that had 50% of all new diagnoses. And the states were 7 states that had a predominance of rural diagnoses. So with this new money, it's not to really continue to fill the holes of the Ryan-White program, and I know they exist, but it's to reach people we had not yet reached. So among people that were in care with HIV, we have about 12% that are not virally suppressed. What do we need to do to reach those people? Among those newly diagnosed with HIV, in this initiative was working to diagnose about 150,000 people with HIV to really make sure that we've improved enhancements in terms of linkage to care and early engagement in care. And finally, the group that I think is most important are those people who know they have HIV, they've been diagnosed in the past, but are not in care. So we know some of the challenges some of these people have. It includes a tremendous amount of stigma, sometimes internal stigma that they feel they've experienced in the community. These are often people that have had been in care at one point in time, but had some problem with transition. Allison is an expert in adolescence, and that transition from adolescent to adult care is still pretty fraught. We know that people, as they go in and out of jail and prison, it is a time where they lose their connections with their care provider. Some people, when they lose their insurance or the way that they were funding things, they don't think there are other mechanisms, so they just don't go back, or they get a bill they can't pay, and that's the end of it. So how do we reach those people? This includes the people that are homeless, people that have severe mental health and substance use issues. I know this is going to take a lot more money and a lot more time and a lot more sort of really diving in deep. So this Ending the HIV Epidemic initiative is an opportunity for us to figure out how to do this. So we started this initiative in the we funded the first part of this initiative in March of 2020, which happened to coincide with the beginning of the big national impact of COVID in this country. So we did not expect to get much done. But in fact, we were amazed at what people could get done while they were standing up telehealth for the first time. They were managing the COVID outbreak in their communities, as well as providing ongoing care to people that were engaged in HIV care. So you can see here the data we had from the first 6 months, where about 9,000 people were engaged in care, which is what we'd estimated would happen even without COVID. So we were, once again, pretty remarkable that so many people receive services. So the first set of bars here show the services for patients that were new to the Ryan White program. And the second lower set of bars shows people that were re-engaging, so people that had been out of care for at least 6 months, but were coming back to care at this time. And you can see that for both of them, the second to the bottom bar, the light blue bar, is receiving outpatient ambulatory health care. These are the services people received. So they both groups were receiving outpatient ambulatory health care, which makes sense. But for those that are new to Ryan White services, ART prescriptions occurred in about 70% of those people in the first 6 months. And a lot of this is rapid ART, or making an effort to start ART relatively quickly in people. The second bar there is EHE initiative services. So with the ending the HIV epidemic, we have more flexibility than we do within the Ryan White program. And we see that over half the clients received a set of services that recipients defined that were sort of outside of the traditional service categories of Ryan White. On the bottom, for those re-engaging in care, in addition to receiving outpatient ambulatory health care, case management services were also predominant there, signifying probably the number of barriers people have to get in care and stay in care, and the fact that those were being addressed early on. So other things that we're doing to support ending the HIV epidemic, we have a specific SPINS grant focused on improving outcomes for Black women, focusing on bundling services. So not providing one service and seeing if it works, but providing a bundle of services that women have needed in the past. We are building the capacity to implement rapid antiretroviral therapy as well. And I mentioned the best practices compilation. So the other two, in terms of developing capacity and increasing data utilization, I've discussed some of those activities already. Another area that we're really focused on is community engagement. Community engagement has been a bedrock of the Ryan White program, and we expect it also in our Ending the HIV Epidemic initiative. We heard from communities across the country that in some places that community engagement for ending the HIV epidemic, figuring out how to reach people that we haven't yet reached, went really well. And in other areas, not so much. So we internally really focused on what we would be doing around community engagement. And we have some guiding principles that our community engagement will be intentional, committed, sustainable, flexible and tailored, and transformational. And we expect that for our recipients, they will do likewise. And that community engagement really starts at the planning phase all the way through development, implementation, and evaluation of care and treatment services. So with that, we do have a community engagement activity for you all. During the Monday and Wednesday breakouts, I will be hosting a listening session from you all. It's going to be the same session, different people, hopefully. So no need to come to both of them. It's really for me to listen to all of you and give you an opportunity to provide input to us in the Ryan White program. It'll be myself and several other members of our team getting input. So with that, I am going to turn it back to Mike for the Q&A. Thanks.
Thanks so much for a wonderful update. You know, having been involved in the Ryan White Care program for many years, it's really nice to see the progression and the responsiveness of HRSA and HAB to the needs of not just the patients, but also the providers. So I think it's reflected in your presentation, in particular, the effort trying to reach the hard to reach. That is something that's just spectacular and we're all concerned about, which leads to my first question. So at the beginning, this dramatic increase in the number of people from 2010 to today who have reached viral suppression, just up to 85, 90%. But that 10% is what we're really working on now. Trying to put that together with the people who fall out of care, it seems to me that it's probably a good portion of the unsuppressed, if you will, that 10%, who are those who are drifting in and out of care. Is that accurate? And can you talk a little bit more about the programs that you have that you've implemented that can help us with that?
Yes, a great question. So we actually don't know a lot about those that are out of care. It's when you try to actually measure it, it gets really squishy because they're out of care. When people come back into care, then those are the people that we know about. So the people that come back into care, yes, it's often those people that we haven't really fully engaged in care is represented by not having viral suppression. But there are people that, for instance, lost insurance, or people that were, I think transitions are important, people that are in and out of jails and prisons, people that are doing well for a while and then they relapse into a form of substance use disorder, or they stop taking their meds for their bipolar disease, or things spiral out of control, they lose housing. So sometimes there are people that have been suppressed for many years. And if you actually look at durable viral suppression, our rates in this country get really bad. And we know one of those areas is specifically around a Ryan White policy around recertification. So we are actually looking at that, and we'll have more to talk about that, I think, in the coming month. But we know that there are ways that we also within our program and our policies need to get out of the way. Likewise, some states, in terms of what they expect for ADAP enrollment, where you have to bring a you have to like notarize your various various documents. Those are huge barriers. So I think it's incredibly complicated and multifaceted. Things that have worked, sometimes you talk about things that haven't worked. So things that have worked are things like, for youth, if you have a really like storefront youth engagement so that they can walk in anytime, that can work. People have had success with doing like housing first initiatives where you're actually housing people. Once again, incredibly complicated and expensive, but if you can do that, that will work. Other ways that people have lower barriers to care. Well, one of the ways was through telemedicine. So when people could call in and talk to their doctor, a lot of clinicians, and this is still anecdotal, but I've experienced it. I think a lot of people have, people that you rarely hadn't heard from a long time were willing to give you a phone call and like talk to you, or you could call them when they were waiting in line for whatever they wanted to do, if they wanted to talk to you then. So by lowering barriers to care, I think there's a lot of different strategies that have worked really well for people.
Yeah, and it's fun listening to your answer, because a lot of what you just went over is precisely topic areas we're going to hear about throughout the meeting, including how to re-engage patients. Dr. Jim Raper will talk about that during this week. The issues of, you didn't say it, but substance use and depression are barriers that keep people out. And I think it's great. There's a couple questions rolling in. Just want to remind folks that if you have questions, hit the Q&A button, submit your question. This question's from Janice Huber, who wants to know about rapid start. We're going to talk a little bit about that in the cases and some of the breakouts, but the concern is that it's kind of expensive, testing done in the ER, perhaps. How do you get that done? Atlanta showed that was kind of pricey. Is there going to be funding for that, or is the juice worth the squeeze in terms of doing that on the day of, or maybe just a couple of days later? What are your thoughts?
Yeah, so I actually don't know if the juice is worth the squeeze to try to really do it on the day of. And a lot of the studies that you look at, including the earlier ones from San Francisco, what proportion of patients actually accepted and moved through? It's not 100%, certainly. So I'm not convinced about the day of. We put out a letter last year about around how people could enroll in ADAP and sort of shorten their time to be able to access growth through ADAP. But the problem is, if a patient comes in and you do use ADAP and you can never fully document that they're ADAP eligible, then the state is on the hook for that. So that's a problem. The Ending the HIV Epidemic does give a lot more flexibility. So through EHE, people have been able to do rapid start more easily.
Yeah. We have another question here, sort of talking about how do we let private practice docs know about the Ryan White program. For example, a patient might be followed by them, they lose insurance. The patient doesn't have a way of paying for care at the private doc offices, but the Ryan White clinic could just be down the street. Are there ways that we can get better communication to the private practice docs for support with Ryan White programs, especially for those individuals?
Yes, so that is something that I think a lot of jurisdictions are working on in part of ending the HIV epidemic. I have a patient I just saw who had been viral suppressed for years and lost his job and ended up with PCP pneumonia. I mean, he'd already gotten insurance again, but he hadn't really restored his HIV care. So that definitely happens. Jurisdictions are doing that because also many of those patients that are seen by private docs might really be able to benefit from parts of the Ryan White program for which they qualify. So it would help to get them engaged and linked to the Ryan White program, even if they have insurance.
Yeah, that's right. Because of wraparound services, exactly. So here's a technical question. Somebody who had missed the cycle to apply, when is the opportunity to reapply for funding through Ryan White?
So it depends through, that is a complicated question. That person should just, might just text me because different, or email me because different.
Yeah. Okay. Here's a question. It's over here to the side, so I apologize. I'm looking away, but our Ryan White clinic had a viral suppression rate around 90% pre-COVID, but now after COVID, it's kind of fallen off. And you mentioned that. And we're going to talk about that this afternoon, actually. So any suggestions? It feels like it's catching up a little bit now. What are you hearing around the country?
Yeah, so that's a great question. It's a really, in the data that I've been able to look at with researchers, it's a little bit confounded because people that were virally suppressed, then they said, fine, I don't need to come back, and they didn't come back for a year or two. And the people that keep getting their viral loads rechecked more routinely, particularly in the early days of the epidemic, I'm thinking, a year ago in May, June, July of last year, were people who were not virally suppressed, and they got a bunch of viral loads done. So I don't know how much it actually dropped because people weren't able to access their medicine versus other types of effects. We do know that many people started doing things like getting mail order and were able to get 90 days worth of medicine. So that went well. And jurisdictions across the country did significantly reduce their barriers to eligibility and getting onto ADAP, for example. But after a while, some states went back to make their sort of previous set of criteria, which were complicated for people in a COVID environment. We don't know the answer to that question yet.
Right. We're almost out of time, and this is a topic we're going to get to about telemedicine. Does the program, Ryan White program, pay for telemedicine? Is that something we're encouraging?
Yes, we've always allowed telemedicine from before COVID. It's in policy 1602, which is, I would suggest that you look there if you have any questions. Our policy clarification notice on our website. Telemedicine's always been allowable. It's still allowable. We don't have a lot of the restrictions that Medicare has had around where people are sitting in that sort of thing in Ryan White.
Yeah. Okay, well, unfortunately, it's all the time we have, but for those of you who have submitted questions that are logged into the program, Dr. Cheever and actually all the speakers will answer those online, just typing back answers to you. So we'll get answers to all the questions throughout the morning or the afternoon here. So thank you very much, Dr. Cheever. A great way to kick off the conference as always. And I'm going to hand over the chairing duties to Dr. Agwal here.